Here I'll be presenting the PGY1 presenting the postcard that Chris Allen called it, but it's basically management of blisters and minor burns. And this, although it was short, it made it a little difficult to gather a whole lot of data from it. So please bear with me, because that, combined with the fact I've never done this, is going to probably be painful. But basically, so what they were trying to assess were 200 patients total enrolled, from my understanding, and they were trying to compare colonization of a burn injury of 1% body surface area that were partial thickness. They didn't specify how many were deep versus superficial, but they said that there was a mix. And then they basically, there were 3 phases of the study, or at least 3 study groups. And one was they left the blister intact, and then they checked to see if there was colonization. Then another group, they kind of aspirated the fluid inside the blister and they checked that. And then the third study group, they essentially, it seems like they were just de-roofed it and exposed it, and then they swabbed the culture from that. And then they compared to see if one group versus the other was colonized with any type of bacteria, and then specifically Staph aureus. Basically what they found was that most, the patients that had the least amount of colonization by bacteria were the ones with the intact blisters, compared to the aspirated versus exposed or de-roofed. And they concluded that it would be better to, in order to prevent infection, is to keep the blisters intact. Another side note is that they also kind of tried to assess for pain between the different types of treatments, and they noticed that the intact blister patients had reported less pain compared to the patients that were de-roofed. So that was of note. A couple of things I wrote down here. Some limitations of the study, at least from what I noticed, is that they didn't really they didn't talk much about the patient's population themselves. So they didn't account for comorbidities or anything that could particularly contribute to their outcome. You know, unknown, like I said, unknown gender, age group, all that stuff. And then they didn't say like how big the blisters were, because I was reading online that, you know, technically if you know, it's okay to like treat them if like the blisters are less than 6 millimeters in diameter, then it's reasonable to just leave them intact or whatever. But anyways, that's besides the point. And I think that's it. And for the therapy form, the way I filled it out were the patients randomized? I put no. Was allocation concealed? No. Were patients analyzing the groups to which they were randomized? They weren't randomized, but yes, they were analyzed within the group that they were allocated. Were the patients in the treatment and control group similar with respect to known prognostic factors? I put unknown because we don't really know much about the participants themselves. And then were patients aware of group allocation? I'm assuming yes, because they weren't randomized. I'm sure they knew whether they were in the aspiration group versus the intact blister group. Same for the clinicians, if they were aware. Were outcome assessors aware of group allocation? Yes. And was follow-up complete? I'm assuming yes, at least from what I understood, yes. I couldn't really calculate, and I'm sorry, I couldn't calculate the confidence interval based on the data provided in this article. I tried really hard, but I just, there was not enough, at least with my statistical background, which is limited, I couldn't calculate it. So I'm really sorry about that. And then were the study patients similar to my patient? So again, we don't know a whole lot about these patients because they didn't divulge that information, but I'm assuming yes. If you see a patient that has, 1%, second degree, partial thickness burn, then, this could be applicable. We're all clinically important outcomes considered. I wrote yes, because I guess they were trying to assess whether there was colonization of the actual blister of different treatments. So I guess, yes, they were considered. And are the likely treatment benefits worth the potential harm and cost? I would say yes. And then I was gonna go over the email. As far as our patient goes, the one with the Instagram model girlfriend, yeah, so his was about a 5% body surface area burn, non-circumferential. And from what I read is that he wouldn't need antibiotics. You can use like some topical bacitracin to treat his burn. And then we wouldn't use sulfadiazine for partial thickness burns because I think it inhibits healing for partial thickness burns. And then he can just be discharged and follow up within 24 to 48 hours. And that's it.
All right. Fantastic. Thank you for going over that with us and for also commenting on the Instagram model portion of it. Yeah, it's an interesting study, right? I think this is one that's coming to us from, gosh, I'm looking at the years exactly. But yes, it's a postcard back when research used to just be the glory days, I suppose. But some things I found fascinating about this, and I kind of want to open it up to everyone else who's listening in, or also get others, other thoughts on these. But, they're looking at, percent of colonization, right? But they're looking at like Staph aureus, and I'm kind of curious, like what other bacterium, grew from this. And also, like, if you look at the numbers of like the intact and the aspirated and the exposed, they don't all quite add up to the, I think, 202 that patients that were fully involved in this. I agree that, again, these are patients with thermal blisters from a burn. So that's kind of what we're generally trying to assess here. But again, kind of going over the comorbidities, like, patients who have who are immunocompromised or poor wound healing or diabetes. We have a very unique patient population with us, especially downtown at Big Barn. So this doesn't quite capture that group, I want to say, or at least we don't know that for sure. So anyways, I'll open this up if anyone else has any other comments or wants to talk about this study.
I actually did want to comment on the number of participants. I was actually thoroughly confused. I even spoke with Dr. Cohn about this because they said together there were a total of 202 participants. However, the N equals, it doesn't seem to add up. And at first I really thought that, I personally was initially interpreted as that maybe these were the same patients and then they were going through different phases of the treatment. Like they were initially left intact for 10 days and then they kept using the terms phase 2, as in like afterwards they were aspirating. But Dr. Cohen was like, well, no, it's probably just 3 study groups. So, and even then it just didn't, like the numbers didn't add up to me. It was very poorly reported. And it was hard to assess if this was just like the total number of participants weren't actually reported or there wasn't enough follow-up. Like let's say it was just 100 participants and each one they decided to progressively change the treatment, then half of those participants weren't even accounted for. I mean, I don't know, this is really, at least in my mind, open for interpretation from what I read.
Yeah, it was a difficult article, I think, as you pointed out. Real quick, I want to show you real quickly how you can calculate these confidence intervals very easily. I mean, you don't have to do any of the math yourself. All you do is plug the numbers into a website. I think Chris had put one website in the chat, but it's actually a different one. I'm going to share my screen and real quickly show you how to do this. Hopefully, if I can get back to the. So here's the website. You guys all see that?
Yes.
Yeah. So all you do is enter the number of patients in each group with the number of patients that had the event in each group. So, Johanna, if you'll give me the numbers for, say, for Staph, who had positive cultures with Staph aureus comparing 2 of the groups. Can you give me the numbers for that? Do you have the table up or the article up?
Yeah. So the intact blister group, Staph aureus 2.
So 2, and how many total patients were in that group?
N equals 110.
110, and then what about the roofed or de-roofed group?
45 for Staph aureus, and then 102.
102. So all you do is plug those numbers in and hit solve, and it literally gives you, if you look down here, the relative risk would be 0.04, and the 95% confidence interval right below that 0.01 to 0.16 or 0.17. So you don't have to do the math yourself because I wouldn't be able to, but just by plugging it into a website, it can give it to you very easily. Does that make sense?
Yes, thank you.
No,
Hey,
no.
Brian, mine will work too. You want me to pull up my screen? It does exactly the same thing.
I thought the one you put was for the for likelihood ratios.
It's for everything. Diagnostics, you just scroll down, you get odds ratios,
Oh,
relative
I see.
risks.
I'm sorry, I missed that down lower. So yeah, either website will work. One other quick thing, I put an old copy of a Journal Club sign-in sheet up, so I'm going to put a new copy up. So those of you who signed in, you'll have to go back in and sign in again. Okay, just FYI.
All right. Any
So if you
other?
were to redesign the study in 2020, how would you do it differently?
Are you talking to me? Just making sure.
Anybody.
I would probably give more information on the participants themselves so that clinicians reading the actual article can determine whether or not this is applicable to their patient, and kind of assess for, you know, any variables, confounding variables and all that. I would also make it clear exactly how the groups are assigned and, you know, how many participants are the total and how many participants are within each group. Just kind of the vocabulary in the article itself was not clear.
Yeah, so you'd probably want to randomize patients, right? So that you get an equal distribution of recognized prognostic factors and unrecognized, the ones you can't measure because you don't know about them or can't measure them. So you'd want to randomize them. And then you'd want to follow reporting standards called consort criteria, which is a step-by-step process that authors and journal editors can use to make sure that you're reporting the same, whether you're reporting a study in cardiology or emergency medicine or general surgery or burn surgery. So you definitely want to do that. You'd want to make it so that it's really easy to repeat. If you give this to a kindergartner, they're able to repeat the methods that you followed, which means you need to describe how the patients were recruited, how the cultures were obtained, when the follow-up occurred, who the patient saw and follow-up, and just all those different factors that this study did not really do. To be honest, the study this occurred when consort did not exist. So the authors, we were benefiting from the knowledge of their mistakes.
Okay. Anyone else have thoughts? Going once, going twice. Okay. All right. Well, thank you for going over that paper, Joe, and thank you guys for those great resources. Okay. Let's go on to our second article. This one comes from Dr. Carpenter and my alma mater at Wayne State University, where we went for medical schools at different times. Anyways, it's an interesting article. Gives me some vibes of sexism, as a surgeon seems to only be a man as it's written in this form. But also, they have medical student volunteers who are getting burned. So I don't know. I guess that was a different time for medical school. But anyways, whoever is going to be going over the PGY2 paper, please feel free to go ahead.
Hey, yeah, so that's me. Messi, I did not know this was your alma mater. I'm surprised you made it out as cheerful as you are.
Oh, from Wayne? Yeah, I guess so. Same for Dr. Carpenter. He's so cheerful.
So I had this paper, I think was published in 1956. Different times, indeed. And just to kind of go over a summary of the paper, so they got medical student volunteers and they subjected them to anywhere from 12 to 16 burns on their abdomen. And they kind of tried to make the burns like identical to each other by taking a 1 centimeter copper cylinder that was heated with circulated water and then applying that to the skin for different lengths of time. And then they kind of separated these burns into 3 different groups to either be left with blisters intact, aspirated, or unroofed, and they wanted to see kind of how healing would be different between the different groups. And so at the end of the study period, they then excised this skin from their poor, sweet medical students. And then made, sorry, my dog is in the background there, and made histological sections and to see kind of how much new epithelium had grown over the burn. And so what they found, essentially, the first 2 sets of experiments they did were identical to each other. They had those 3 groups of intact, aspirated, or unroofed. And at 5 days, they looked at the growth radius as kind of a measurement of how much healing had occurred at that time. And they found that really there wasn't a statistically significant difference between the 3 methods, but that intact blisters trended towards better healing. For the second of the experiments, they took the 16 burns and they had different contact times. Or no, sorry, this one they had 45 seconds of contact time, so they were all the same. 6 of the blisters they left intact. The remaining 10 they split into a group that was unroofed at 5 days and a group that was unroofed at 8 days. And they compared healing that way. And so for that experiment, they did find that at 5 days, there was a significant difference between healing in the intact blister versus the unroofed blister. At 8 days, there was still a pretty strong trend towards improved healing with the intact blister. So they torture their medical students, they come up with these findings, and then they conclude this will probably not impact or change practice in any way. So I feel terrible for those medical students probably reading this paper, had their souls crushed. So going through the therapy, the critical review form for this paper, the first question is if the patients were randomized. They weren't really randomized, they were their own controls though, so I think we can assume that there weren't differences between the 3 groups in factors that might affect healing otherwise. It asks if allocation to each of the groups was concealed, and again, no, it wasn't. We knew which groups were receiving what treatments. The next question is if they were analyzed in the groups to which they were randomized. And yes, I think they, set out with these 3 separate groups. They didn't really elaborate on whether or not, if they were trying to keep a blister intact and then there was some incident and it got popped or unroofed, if they changed what group that blister was in. It doesn't sound like they did though. It seems like if they were randomized to the blister group, they were analyzed as part of the blister group, the intact blister group, was my understanding at least. They didn't specifically comment on that. And then the next question is if the patients in the treatment and control groups were similar, and yes, they were identical, in fact. The next kind of section of questions, were the patients aware of group allocation? I think, yes, they were aware of kind of which blister was in which arm. So I guess they could have maybe had, if they wanted to influence the results, be taking better care of one blister than another. But I think that's probably unlikely. The clinicians were also aware of which group was which because they had to unroof the blisters and they had to aspirate. And so they would know then. They don't actually comment on whether or not the outcome assessors were aware of the group allocation though. So I could see potentially trying to guard against bias if they had just presented somebody with these slides and had them analyze them and say kind of what they thought the growth radius was without them knowing, okay, this is the intact blister, so I expect it to be better. That would have been a good way to try and control against some bias there. And they didn't say whether they did that or not, but it certainly would have been possible in this study. And then the last question in this section is if the follow-up was complete. I think it's kind of difficult to say. They didn't follow the patients all the way until all of the blisters were healed. So that might have been a way to kind of get a better idea of the difference in like length of healing between these three different groups. If you look at table 2 here, it just says, you know, we followed them out until 14 days. And at 14 days, all of the intact blisters had healed. Most of the aspirated blisters had healed, and a little bit of the unroofed blisters had healed. And so it would have been nice to follow out and see like how long it took the unroofed blisters to heal, and then kind of present that comparison to the intact and aspirated blisters. So next we're talking about kind of how large the treatment effects were. So looking at table 1, which was the results from the first 2 studies where they just had the 3 separate groups, and at 5 days we looked at how much growth radius had developed. They acknowledge that these results aren't necessarily statistically significant, but we did mention that the intact blisters trended towards better outcomes, and that effect was anywhere from 0.3 millimeters of additional growth to 1.2 millimeters of additional growth. For the second study, where they're looking at the growth radius at 5 days versus 8 days for intact versus unroofed, that one, they did have a statistically significant difference at 5 days. That was 0.4 millimeters of growth difference between the intact versus the unroofed. And then for 8 days, it was 0.7 millimeters about difference in growth between the 2 groups. And so that was kind of the treatment effect. The question of how precise was the estimate of this treatment effect, they don't provide us with any confidence intervals, and we also don't really have any kind of raw data, unfortunately. They do provide in table 3 for the second experiment of intact versus unroofed. They provide ranges for the different treatment arms. And so at 5 days, the range is actually pretty narrow. It's like within 0.2 millimeters at day 5. But then you can see as you get out to 8 days, really, while intact still trends towards better, the ranges in the 2 groups are much larger, 1.1 millimeters each. So seems to kind of vary much more at that point. So now kind of moving on to how we can apply this to our care. It asks if the study participants are similar to my patient population. I think the answer is probably no. They took medical students who seem to be all male based on the beginning of this paper. I don't know, maybe not. Maybe there was a woman in there somewhere. Probably not very racially diverse at that time either. And then being medical students who are, you know, trying to oppress their surgery attendings who forced them to enroll in this study, they probably were being extra careful to take care of their blisters and like not pop the blister or like not pick at it, not get it infected and things like that. So that's probably a lot different than what we will experience in our patient populations. So not totally applicable to us. They ask next if all of the clinically important outcomes were considered. They did mention that there were no infections in any of the groups, so there's no kind of like bad outcomes with whatever route you choose. But they didn't really comment on like patient comfort or patient pain. To try and preserve these intact blisters, they had these poor medical students walking around with like cardboard strapped to their belly, which I think is probably not something we could feasibly do for our patients. So I think those are kind of some important outcomes that weren't considered, and that kind of feeds into the next question of, are the likely treatment benefits worth the potential harm and cost? I mean, the benefits that they're talking about here are millimeters of growth. You could say maybe there is some like more substantial benefit with like at day 14, are you healed or not? But I still don't think that's probably worth the like discomfort and precautions you would have to take to try and like preserve your little blister, you know, intact on your arm, regardless of, you know, your future careers as an Instagram famous model. So yeah, that is kind of what I got from this study. Like, yes, maybe it's a better environment for the skin to heal in an intact blister, but likely not something that we can feasibly do. And the authors actually concluded a pretty similar, yeah, they had a pretty similar conclusion where they said, like, thank you for your service, medical students, but we will continue with our current practice.
Mm-hmm. Yeah, no, great job, Dr. Groff, and thank you for doing an excellent job explaining it and giving the shout out to these volunteers for their sacrifice for medicine, I suppose, back in the 50s. I agree with you. I think this was a step up compared to the previous study in the sense that the methods were a little more sound. And as Dr. Carpenter had alluded to, you want to kind of create steps that someone could easily reproduce and have a little more values that you can also have people follow a little better. So I think their methods were better. And you know what, maybe those med students just wanted to feel something again, aside from like the soul crushing life that, I don't know, we all kind of remember maybe a little too well from medical school. But you know, with that being said, I think that's a great point too. You know, they only looked at really one facet, which was, you know, what is this healing? What is this epithelialization? And they even kind of looked at like the histology of it. I also want to give a shout out to these authors for using the word moist quite a bit. So they're bringing it back, I guess. But yeah, you know, they had looked at a very short-term outcome. You know, like the other studies that we will look at, and especially this Cochrane review, we're going to be talking about follow-up for almost a year out. And I think that's a little more important, especially now as I would imagine in today's field of medicine, we have kind of swung away from like paternalistic medicine, which maybe was a bit more of the 50s. Which was, I don't really care about your pain. I just kind of care about like, you know, what's the healing or what the or maybe not what the patient cares about, but what the clinician cares a bit more about back in that day. So I'm going to open up the chat to anybody else who has comments on this paper or their take on it as well. But thank you again, Veronica.
Mm-hmm.
It's not a randomized control trial, so it really, like you said and like the author said, gives us no clinical implications as to should we do this or shouldn't we do it? Is it cost effective? Does it have patient-centric benefit? It doesn't answer those questions. It is cool though. We don't do histologic studies at Emergency Medicine Journal Club very often, and they clearly show how the wound periphery with the blisters, the epithelium is thicker, and they explain histologically how you regenerate or you heal the wound as those epithelial cells climb over the burned papillae of the dermis, and you can understand theoretically the biological plausibility of why leaving a blister intact would promote wound healing and give the results that they got. So I think it's very cool from that standpoint. It gives us the basic science explanation of what the next paper is going to try to prove.
As somebody who doesn't always do randomized studies of human patients, I can feel the the pain of the authors as they would hear Chris's comments. But I mean, there's things to be learned, I think, from this study, even though it's not randomized. And certainly, I think there's things you can learn from any non-randomized study that goes into the depth of the basic physiology. So I think take those things into account, and we probably should have more studies like this with histology and emergency medicine. It would be helpful in a lot of ways.
Yeah, the authors were equally harsh on themselves. On the third page of their study, it says, it is not believed that this study has many implications for the management of clinical burns. Talk about no spin zone.
I liked the discussion at the end, by the way, where they're talking about the questions for the authors, and they're saying we still force feed all of our burn patients 5 days after their injury, that's very interesting.
Yes, that was also great, and it also made me hungry too thinking about it. Food is meant to be enjoyed, but you know. Okay, anyone else want to throw out the word moist one more time, or any other comments? Thank you everyone for giving their feedback. This is great. Going once, twice, moist. Okay, we'll move on to the third article here then. So this one, a lot more recent, I believe this is a 2018 article, where again they're trying to look at, in this case, just aspiration versus unroofing of thermal burn blisters. That's all I'm going to say. I'll save my other comments for the discussion at the end. But whoever will be presenting for the PGY3s, please feel free to go ahead and give us your take on it.
Hello, guys. It's Elizabeth. Can you hear me okay? Great. Okay. So this paper is titled Effectiveness of Aspiration or De-roofing for Blister Management in Patients with Burns, a Prospective Randomized Controlled Trial, published in the Journal of Medicine in 2018, as Messi said. So unlike the others, this is an RCT by design, essentially looking at aspiration versus de-roofing or debridement of burns. So it's a pretty small study. They had 40 patients, and they were ones who had either presented to the ED or to an outpatient plastic surgery clinic. They enrolled patients over a series of about 6 months in 2016, and it was all done at a single center, I believe in Korea. They included patients who had burn blisters that were greater than 6 millimeters. They randomized the patients with a coin flip to either the aspiration group or the de-roofing group. They said the patients were blinded to the intervention, although I'm not totally sure how they did that. Maybe they had them like wear a blindfold or something. And then they had board-certified plastic surgeons doing the assessment of the burn healing and scar formation in the follow-up. They specifically called out they had similar like post-procedure treatment in both groups. So both groups had the same kind of like topical antibiotic and non-stick dressing after whatever kind of intervention they were randomized to. So the study population included adult patients greater than or equal to 18 years old. They excluded patients with what they called severe systemic disease or any psychotic disorders. They didn't really get more specific about what they considered severe disease. And then they excluded anybody who at the time of randomization already had a ruptured blister or who had had any kind of treatment prior to being enrolled in the study. So as far as outcomes in this study, they looked at 4 main things. So the first thing was time to wound healing, and they defined that as re-epithelialization or specifically absence of any oozing from the wound when they took the dressing off, as assessed by one of their plastic surgeons. They also looked at what they called functional and aesthetic outcomes. So they used this scale called the Patient and Observer Scar Assessment Scale. And they had the patients and the surgeon do this assessment 4 weeks, 3 months, 6 months, and 12 months out from the initial treatment. And apparently this is a validated 10-point scale where 1 represents totally normal skin and 10 is the worst scar imaginable. And so the patient and the observer would each kind of rate the scar on this different points of this scale. And then they also had the patient rate their pain on a visual analog scale. Specifically, I think pain with dressing changes on day 1, 3, 7, and 14. And this was on the 0 to 5 scale, with 0 being no pain and 5 being the worst pain imaginable. And then they also swabbed the fluid from the that was aspirated from the blister, or just swabbed like the wound bed for the debridement group at the time of the initial intervention, and then days 3, 7, and 14. So those were kind of their 4 groups, like categories of outcomes that they looked at. So if you're looking at the paper, the main kind of characteristics that they summarized of the patients and the burns that they included in the studies are in table 1. So they kind of break down the sex, age, cause of the burn, percent of total body surface area, which ranged from 1 to 10%, and then site of the burn, and size. They specifically broke it down into small ones that were 6 to 10 millimeters, and then large ones that were over 10 millimeters. Although it looks like in both groups, the largest like total body surface area was 10%. So presumably these weren't like massive burns. So in table 2, you can see that they summarize kind of their first outcome. So this is time to wound healing. And they look at kind of the aspiration group versus the de-roofing group. And it's pretty similar for both groups. It's about 12 days. And this is sort of regardless of the body location of the burn or the size of the burn. They later in the paper attribute this to kind of appropriate wound care for both groups. So they say, you know, these were dressed with antibiotic ointment and nonstick dressing, and both groups had this variable was controlled. So that's probably why they had similar time to wound healing. There were a small number of patients in both groups that developed an eschar and required like a more extensive procedure. So it was 1 to 2 patients in each group. Each group only had 20 patients, so pretty small numbers that they're working with. In figure 2, so this is that rating scale that they have both the patient and the objective observer kind of assess the scar over time. So you can see kind of the aspiration group and the de-roofing group. The numbers are slightly higher for the de-roofing group on both of these scales. And so higher numbers are kind of a worse scar as assessed by the patient and the objective observer. Although, as they point out in table 3, the outcomes at 12 months are for the most part not meeting their criteria for clinical significance. There are a couple of these kind of like subcategories of this rating scale that meet statistical significance, p-value of less than 0.05, but they don't ever really kind of explain, like, is there clinical significance of, you know, the difference. You can see here, like, for example, the thickness of the scar being 3.25 in one group and 3.75 in another group, while it meets statistical significance for the p-value. I don't really say like what specifically that means clinically. And then in figure 3, they are showing the patient assessment of their pain scores over time. So you can see that in both groups, it declines pretty dramatically after day 3, kind of minimal pain rated on this 0 to 5 scale after day 3, and very similar between the 2 groups. And then in table 5, they show the rates of colonization. So they swabbed each of these wounds for bacterial culture. And they show kind of at day 3, 7, and 14, the rates of positive cultures for each of the groups. And the numbers are slightly higher for the de-roofing group as compared to the aspiration group. So overall, essentially they show that there is a slight advantage for the aspiration group in a few of these long-term scar kind of assessment scores, but overall the outcomes are quite similar between the 2 groups. And essentially the numbers were so small that there really isn't a lot that seems to be either clinically or statistically significant here. So I think a strength of this paper is that they tried to do a prospective randomized and blinded study. They were trying to kind of get at this question that has not really had a lot of high quality data to go on. And then they did focus on some sort of patient-centered outcomes, specifically things patients care about, like long-term scarring and kind of functional, you know, how they feel 12 months out, and then how their pain is in the near term. I think my biggest criticisms of this, they had a very small study size. They only enrolled for a couple months. They didn't say why that was, but I think if they'd had more patients, they might have been able to make a stronger argument. They didn't include any kind of control group that didn't have an intervention. So as some of the other papers have kind of alluded to, there's this question about, should we do anything for blisters? Should we just leave them? or should we do something like aspirate them or de-roof them? And so I think by not having a control group where they did no intervention, they maybe kind of missed out on a chance to answer that question. And then there were a couple other things I felt like they could have addressed but didn't. So like they used kind of pain assessments as one of their outcomes, but they didn't really talk about if all of these patients were given like a similar pain control regimen, like maybe some of them were given opioids, maybe some of them weren't. Just kind of something that occurred to me is, could definitely be a confounder. They didn't really collect a lot of other data on patient characteristics that could impact wound healing, so things like other comorbidities. They didn't have too much to say about that. And then because they excluded patients with severe systemic disease but didn't really define that, I'm not totally sure that this is applicable to, say, like our ED population. But again, it's hard to say. They don't really define it. I think they potentially did miss out on some other outcomes that we care about too. I mean, I know they were kind of working within the design of their study, but they didn't really address things that we care about, like ED length of stay, kind of other complications that these patients could have encountered, like if any of them actually had developed wound infections or anything else like that. So those are kind of just my thoughts overall. In going through this therapy review form, so we've kind of covered a lot of this already. The patients were randomized. They reported that the groups were pretty similar, although somewhat limited kind of baseline analysis of the different groups. Let's see, the patients, they said, were not aware of the group allocation. I'm not totally sure how they blinded them to that. The clinicians, I think, were aware as the ones doing the procedures, although the ones doing the assessments, the plastic surgeons, reportedly were not. I think they did do a pretty good job with like completeness of follow-up. There were very few that were lost to follow-up, and they followed most of them out to 12 months, which I think is pretty good. So how large was the treatment effect? I mean, I would say overall, I think there's like minimal clinical significance to any of these. Very few of their study endpoints met any statistical significance, but like I think more importantly, none of this really seems to have a lot of clinical significance to me that kind of points in one direction or the other as far as the two interventions. And then because the effect size was so small and the study numbers were so small, there really can't really make an estimate of how precise any difference is. I think we pretty much talked about these other things. I don't know if this is totally applicable to our patient population. It's obviously a single center in another country. It's not exclusively ED patients, so there's some limitations there for applicability. And then overall, I don't think this really changes how I'm going to think about sort of these two interventions in the future, but I think they made a good effort here.
Great. Okay. Thank you so much for going over the analysis of the paper. I agree with a lot of your criticisms of it. The positives, it was definitely, again, like we're kind of improving in regards to how the methodologies are done. Like this was a prospective, randomized, controlled trial. They tried to have concealment, but I agree with you, Elizabeth, where it's like, if you take off a bandage and you look at it and there's clearly like, I think you can tell when a wound has been recently debrided, like there's none of like the loose skin attached to it as opposed to aspirated. I'm not sure how you can be completely blinded to that. But I did appreciate that they looked at more patient-centered outcomes, like, and for a follow-up of about a year as well. I think it's great that they looked at the pain and that there was some significance with less pain in the aspiration group. And I also agree that I wish that they had in the control study, which is the just stand there and do nothing group with the blisters, just leave them intact and see what happens. I think that is probably my biggest criticism of this paper. But again, a step up compared to the ones that we reviewed so far. Anyone else have any thoughts that they would like to bring up on this? Feel free to join.
I thought there's some interesting lessons that this lets us take away beyond what the author's primary objective was. One is that patients consistently rate their wound appearance worse than the plastic surgeons at any time point. We should keep that in mind when we're discharging patients, how they're going to assess their wound healing. They also consistently have higher pain when you de-roof the blister. We need to keep that in mind as we consider any other benefits of de-roofing, that pain is more. Then the other point that I was going to make about the commentary was that the small sample size, I agree, is generally a red flag, but it's not always bad. How would you determine, Elizabeth, if a small sample size is all right?
I mean, I suppose you could do a power calculation.
Yeah. And did they?
I didn't see one.
No, they didn't. So we don't, a sample size, if you have a big effect size, can be very small and still be a definitive study. They just didn't do a sample size calculation. So we have no idea whether this sample size is too small or not. My inclination is it probably is too small, meaning that there might be a chance of a type 2 error or a true effect size somewhere in the study that's being missed because we didn't look at enough patients. We missed it. And to case in point for that, and a little bit of spaced repetition, do you guys remember Ian Ferguson's lecture a couple weeks ago? Frequent statistics versus Bayesian statistics. So look at their outcome for bacterial colonization in the aspiration group is 15% in the aspiration group versus 40% in the decolonization group, not statistically significant by frequentist statistics, p equals 0.15, but that's almost 3 times more bacterial colonization rates. That seems to me pretty clinically significant. And I bet if you use Bayesian statistics on this, that would be significant. So again, we're stuck in this p-value mode because we have been for 100 years, but we need to probably start thinking the way Ian was telling us in lecture a couple weeks ago and thinking about Bayesian statistics, because that might be a pretty important difference in favor of aspiration versus de-roofing.
Yeah, no, that's a really good point too.
Can I ask you a question? Do you think that this kind of like swabbing the wound and looking to see if any bacteria grow on the swab is a useful clinical assessment? Because to me, it seems kind of like if you swab skin and grow a culture, you're going to grow some skin flora. So is there good evidence that shows that swabbing a wound bed or like the fluid that comes out of a blister is actually useful?
That is exactly what I was going to bring up here, which is, again, we're reporting colonization. It's kind of like the same when we do like blood cultures, right? Like, oh, great, it grew something. Is that contamination? Especially because we know our skin is the biggest defense barrier. It's always covered with bacteria. I would be more encouraged to find out if there were like significant like infections, like when they report like mortalities and stuff like that. I think this was great that the study did report what patients did have to go for like escharotomies and such like that. And I kind of got the vibe, again, this is just my interpretation, that there was low risk of significant bacterial infections based on the morbidity reported from this. But I agree that's something that, so what if it's colonized, right? Like what does that really mean clinically for us? My 2 cents.
Elizabeth, what might have been a better way of measuring that outcome, or a better way to measure a clinically important outcome than just culture results?
Well, I suppose, I mean, the thing that we would care clinically is, if somebody actually developed a cellulitis or bacteremia or something like that, if there was a clinically significant infection that we were going to actually do some different management for.
Yeah, so diagnosis of cellulitis, antibiotic administration would be another thing to look at. If someone needed enteral or oral antibiotics or IV antibiotics for this, that would be a clinically important outcome. I agree with you. The results of a culture swab or not.
Yeah. So those are the 3 papers. Again, very limited literature out there and not great literature, so to speak, by our standards today regarding burn debridement and otherwise, stable patient who would be fine for discharge. I mean, again, we're not trying to capture the patient who's got to be transferred to like a burn center or anything like that. But, the patient who comes in who just has like a partial thickness burn, otherwise well appearing and would be discharged, do we need to do any interventions? And so I open the floor to everyone here to kind of give me your thoughts on that. I'll kind of personally go first, with the research that I've done, there is, and I can understand this from like a burn surgeon perspective or someone who focuses solely on burns, the biochemical and the physiologic compounds that make up the blister fluid, that is a whole separate like can of worms. That is a rabbit hole that you do not want to get into. And there are so many studies that have looked at that and looked at those biochemical components and what those mean. But I think for us in the emergency department, getting to see these injuries first, we care more about like the patient-centered outcomes, about the clinical outcomes, as opposed to the physiologic things that are going on. So for me, for a patient who I feel would otherwise be fine for discharge, doesn't have a large body surface area injury, and no indication for like a burn transfer or anything like that, I kind of feel like just covering the area, giving them return precautions, and having them follow up would be appropriate. Now, granted, if I think it's a big blister, maybe I would, aspirate it or lance it. But, I don't really feel inclined after these studies, again, they're not great, to say like, I'm going to give you a ketamine sedation and do a full debridement, like an ouchless scenario. So that's my 2 cents. But again, I'd like to hear everyone else who has an opinion, go ahead and voice it.
I was trained to leave them intact. In Pittsburgh, we never talked about the level of evidence or went over this degree of analysis of the literature, but I was just trained to leave them intact. The exception is if the patient is extremely concerned about this blister, the size of it, the appearance of it, please lance it, please drain it, please do something. If they're going to not be able to sleep at night because they haven't done anything but cover their blister, I'll drain it with either lance it or drain it. I do think it's worth having some shared decision making with the patients now that we're aware of what the literature is, and talk to them about the lack of evidence for any particular approach. And I also think, I don't know if our surgeons are on the line or not, some of our burn surgeons were going to join us if they could. The American Burn Association specifically recommends lancing blisters. The emergency medicine literature specifically says, Adam Singer is the guy who's done most of this research in our field, says don't lance them, don't drain them, just cover them, as long as they're not large, but he doesn't really define what large is. So there's discrepancy between the burn community and the emergency medicine community. I think it has to do with the spectrum of burns that we see. We see the really minor ones that burn themselves on a pot and are sent home. Then the burn people see the ones that are admitted and that go to surgery a lot of times.
I think that's a really important point that Chris just said. If you, even with those last paper, that the total body surface area, the average was 3.5%. The burns themselves, 80% of them were less than 1 centimeter in size. So my guess is the burn surgeons aren't seeing those. They're seeing much larger burns, which, does shift your paradigm of, I'm not saying what they do is necessarily correct, but it does change the paradigm of, if someone's whole forearm is burnt and they're still going to go home versus if they have a burn, this big.
It's like Jessica Nelson has an opinion.
Jessica, do you want to say anything? Or I don't know if you're working, but she is just making a comment.
Oh yeah, I'm here. I don't know how good my connection is.
That's okay.
So I spent a lot of time in our burn ICU and fellowship, taking care of a lot of these patients. So typically what I've seen most burn surgeons that I've worked with do is if the blister is large or impairing mobility, like if it's, on the hand or on the wrist or over a joint or something like that, where the patient is then not going to utilize the joint, they will drain the blister. Otherwise, for the most part, if they're like small blisters not interfering, they'll usually just leave them. And then obviously, for the most part, the rest of burn care is focused on like larger burns, in terms of what burn surgeons will actually do. But a lot of what we are managing here is more outpatient management, and the data is not as significant. But things like, hyperalimentation and vitamin C is really looking at more. Hyperalimentation is 10% TBSA, and vitamin C is, greater than 20% TBSA. So yeah, for the most part, I agree with what other people have mentioned, which is if they're large or bothersome, I will drain them, but oftentimes I will, if they're small, just let them be, and they'll drain on their own.
Yeah. All right. Thank you for all the feedback. And again, if anyone else has anything else that they want to add, please feel free to. I think
a question I wanted to bring up, just because this comes up again and again at Journal Club, it seems, but we often don't have time to talk about it. But tonight we do. Why are these things that we see so commonly, like burns, we probably see 10 times a day in the our emergency department, and maybe 100 visits a day around the city of St. Louis? How come there's no studies looking at this?
I know.
And you can say the same thing for almost anything that we treat in the emergency department.
You know,
Have
I
we not
think
trained enough research? Do we not have enough research funding to do it? Are we too young of a specialty? It's kind of an existential type of question.
what are your thoughts on the follow-up though, Chris? I feel like that's the one thing that we lack with our patient population is, will I ever see this individual again? Or how do we ensure that? And I think that would have to be like a bit of a partnership. But maybe now that we're getting this telemedicine thing off the ground, to be like, hey, show me your wrist, or, you know, show me the area and let's have a look at it. That might be a lot easier for follow-up now.
I think that might be a little bit overblown, Dr. Messenger, I mean, we do follow up routinely for research studies, and especially phone call follow-up. Like if you're looking at, is your wound gone? Are you still having pain? I mean, those things would be super easy and even super cheap for our ECRC research coordinators to do. And even a follow-up visit just to measure a wound and see how much it's healed. That's a very relatively cheap thing to do. So I don't think those things should be ultimate barriers. I was going to follow on with what Chris was saying anyway, and also his discussion about power analysis for whichever resident wants to take up this question, which they could have a great paper, I think, in like a year of work. But power analysis is really something that should be done with study design before the study is undertaken. And I mean, I think you need to know what your effect size you're expecting is and what you think is an important difference. So if you think an important difference is a 20% difference in healing, then you can easily calculate that out on a power analysis. If you just say, I'm going to recruit 20 patients here and 20 patients there, and then see what my power is to determine a difference, you're probably going to say that you probably only have a power to determine if there's a difference of, I don't know, 50% between the healing. I don't know what the exact number would be. But there's a way to do those calculations a priori, and they should be done a priori whenever you design a randomized study, especially when you design a randomized study, because you're already taking the time to prospectively do something. So keep that in mind if you pick up on one of these interesting clinical questions that are understudied in our field. Take the extra weeks while you're doing your IRB to think through your study design and design it the right way.
There's an app for that too on our Journal Club website for the residents who want to check it out. I just sent the link.
All right. Well, I was, like I said, when I initially thought about this topic, this kind of stemmed from more of the pediatric side. And I'd asked some of our PEM colleagues if they had any literature, or because I feel like, and feel free to chime in, anyone else who works over there, especially the residents. You know, I have seen a bunch of younger, healthy pediatric patients who, you know, have like a skull injury or something like that. And I'm like, oh, this looks great. Like I could just, you know, put some bacitracin over it. We have pause follow-up for them. Like follow-up is really good over there on the pediatric side, thank goodness. But, you know, then it's always like, no, we should debride them. So anyways, I'm not saying that this translates over to the pediatric side, but I would be interested to also follow up on something in regards to that, because that's, again, increased length of stay, placing an IV in a kid, giving them a ketamine sedation, or making things painless. So maybe just another avenue as well for future research. Okay, well then, we're gonna briefly change subjects here. We're gonna talk about a Cochrane review. As Dr. Schwartz pointed out, the PGY1s had a postcard to review, and the PGY4s have a litany of literature to look through, but it's an important topic, I think, because that's the other half of our decision, which is, okay, to debride or not to debride, but then like, what do I give them? Do I have to give them essential oils? Do I tell them just to keep it dry? Like, where do we go from here? And we always kind of fall back on the default of silver sulfadiazine, just because like that's, you know, what we've been kind of indoctrinated to use. But, you know, is it really the best option? Are there other options? And Craig McMahon, who couldn't Zoom in with us today, but he sent us some information on regards to what we have in our pharmacy at WashU. So what could potentially be options for us outside of the SSD. So whoever will be presenting for the PGY4s, feel free to go ahead and give us your take on it.
I realize this will take about 3 hours to get through this article, but talk about Cochrane reviews at the end a little bit too.
All right, looks like I'm up. Can y'all hear me okay? I'm on a lounge computer.
We can hear you, Alex.
You can hear you.
Yes.
Okay, good. All right, great. So yeah, this Cochrane review looked basically at what different topical therapies for burns, which is a reasonable thing to look at. Turns out if you survive your burn in the acute phase, 75% of mortality is secondary to infection. So it's kind of an important question. The way it approached this was to sort of clump the different RCTs by like what they were comparing. So for example, they have three main groups. They have the RCTs that compared antiseptics to topical antibiotics. Most of I think actually all of the topical antibiotic, quote unquote, was the standard, the typical silver sulfadiazine. So that was one group, some antiseptic versus silver sulfadiazine. Then another group that they looked at was antiseptics versus alternative antiseptics. And then the third group were antiseptics versus non-antibacterial comparators. And there was some weird stuff in there that they were comparing to. But those are the three groups. They looked at, the studies that they looked at were basically all comers. Literally all burns of any kind, of any severity, for any demographic, of any total body surface area. They kind of pooled every single RCT they could find for any burns, and they came down with, I think it was like, they pulled like 1,500 studies or so, and they narrowed it down to 56 studies that had qualitative data that they could look at. There were some secondary outcomes that were qualitative, and then they ended up including 44 studies in their overall quantitative meta-analysis. Unfortunately, I just start with this before I jump into some of the details. They had to, it turns out a lot of the studies were either small or poor quality, and the way they had to clump these, these different RCTs, there was a lot of imprecision and indirectness just because there are so many different kinds of therapies, and some of the secondary outcomes, which we'll talk about, just didn't happen very frequently. So the low number of events made it, it kind of dropped the quality of the evidence. So we can jump into some of the things they found here. Oh, and the way they analyzed the data before we jump into it is they calculated if the RCTs provided enough quantitative data, they calculated a hazard ratio. If they couldn't, they would do a relative risk of healing, and then in the worst case, they would do like a difference of the mean if it was if they couldn't calculate any of the above. So primary outcomes, what were they? They had two primary outcomes. One was wound healing, which they, depending on how the study reported it, was either a time to complete healing or just the frequency of healing. And then the other primary outcome was change in infection status. So that could either be an uninfected wound becoming infected, or a chronically infected wound clearing the infection. So those were the two primary outcomes. Secondary outcomes were a couple of things. So adverse events, including infection, quality of life, pain, including at dressing changes, and then resource use and mortality. So, and resource use included costs to the patient. All right, so, well, I guess the easiest way to do this would be to kind of start with the summary of the findings, since there's kind of a lot. So, for antiseptics versus topical antibiotics, this is the first group, and these were, again, antiseptics being compared to the silver sulfadiazine, what we're all very familiar with. They found a few things. So, low certainty evidence that silver sulfadiazine is pretty much about as effective as as other silver-based antiseptics. So that's probably not super surprising. They found a mean reduction in length of in time to heal of 3 days, which I don't know. They basically said that this is based on the evidence. It's probably no different. There is moderate certainty evidence, surprisingly, that honey is actually more likely to lead to wound healing over time compared to silver sulfadiazine. So that was an interesting finding. Hazard ratio there was 2.45. So honey, probably more effective than silver sulfadiazine. There was low quality evidence for sodium hypochlorite, and then that's the other ones are kind of exotic. The antiseptics versus alternative antiseptics. This is the second group. The only reported conclusion here was that when looking between iodine and chlorhexidine, they did find that, and this is low or very low certainty evidence, iodine versus chlorhexidine, that iodine may reduce the time to healing, and again, low certainty there. And last group, antiseptics versus non-antibacterials. They found a couple of conclusions. So honey was the antiseptic in one of those studies. They found that with high certainty evidence that honey is way better than nothing, essentially, or alternatives, non-antibacterial alternatives. That's probably not surprising. Honey has some fairly well-established antiseptic qualities. There's that. There's also they found that nanocrystalline silver dressings, which is one of the silver-based antiseptics, these dressings have faster healing than those treated with Vaseline. Difference there in about 3.5 days. So probably no surprise there either. And then, you know, I did mention a lot of secondary outcomes that they tried to look at. Unfortunately, the study the Cochrane review came short of making any sort of conclusions, mainly because there was so few events that they couldn't really draw much conclusion. So, you know, in terms of infection, which of these interventions is more likely to prevent infection or heal an infection, this actually could not state give us any recommendations on that. The last thing they were able to conclude was that mortality was in general low, and so, which is not surprising, given that most of the studies, and I forgot to mention this, most of the studies, the vast majority that they ended up analyzing had a 2nd degree burn or less, and less than 40 degree total body surface area. Some had more, up to 60 or so, but the vast majority were less than 40% total body surface area. So really these conclusions, and they're not very strong, are only applicable sort of to that population. And this is kids and adults alike that they analyzed. Let's see if I'm missing anything here. That's sort of it. So I guess in conclusion, we can go down the list here on the form. Did the review address a sensible question? Yes. We talked about the mortality of burn infections. Was the search for relevant studies detailed and exhaustive? Yes, it looks like they really did try to pull, you know, as much as they possibly could, and picked from it as much as they possibly could. And unfortunately, it ended up not being enough to make some strong conclusions, but they tried. The studies where they have high methodological quality. So this is one of the issues that they kept on running into, is again this indirectness and imprecision. Like there were, for example, for pain, there were like unvalidated scales that were used. There were different scales across different studies that were used. The infection thing, like some of them, like we talked about earlier, they would use culture positivity as a surrogate for infection, which again, what is the clinical significance of that? So there's a lot of, again, indirectness in these studies that made it difficult to draw any concrete conclusions. And again, the number of infections and the events that they were looking for were just not, the frequency was just not high enough to reach statistical significance either. were they reproducible assessments? Mostly, but again, this imprecision sort of undermines the reproducibility. It'd be nice to have more evidence-based ways of evaluating these, the things that we're looking at. What are the overall results? We kind of went over that. Basically, in short, the big punchlines here: honey is awesome and might even be better than silver sulfadiazine. If you only have iodine and chlorhexidine, I don't know, toss a coin, maybe go with iodine. And then if you don't have silver sulfadiazine, but you only have some other silver-based antibiotic, you're probably fine with the silver-based therapy. How precise are the results? Fairly imprecise. Again, most of the things were low certainty, some moderate, and then let's see, the results similar from study to study. Yep, the ones that they pooled and the ones, they actually were fairly consistent. That's what, if you look at, I forgot what these graphs are called, but the subgroup analysis were fairly, nothing was too erratic there. Nothing was too surprising. And they were all sort of around the mean or slightly favoring honey in honey's instance. Instance. Let's see, were there results similar? Yeah, we said that. So how may I best interpret the results? Again, we sort of talked about those conclusions above. Go with honey if you don't have silver, or honey may actually be better than silver. Important patient outcomes. They tried. I think they did the best they could going for patient-centered outcomes, but they just came short due to the lack of events, and again, the how much they had to downgrade the quality of evidence due to either bias, imprecision, and indirectness. And then, are the benefits worth the costs? Well, I think so. And definitely you want. Well, this was not is a therapy better than a control? Like, I think this was more of a mostly comparison of alternatives to silver sulfadiazine, which we can, I guess, consider largely the standard of care. And if we're talking about honey specifically, since that's the one that had the best evidence, I am kind of interested. Honey is I would imagine cheaper than silver sulfadiazine, although someone can maybe correct me on that. But given the results, fairly interesting, maybe promising. It'd be fun to take a look at that in the future, I think. And that's what I have from this Cochrane review.
Awesome. Thank you so much, Alec, for taking on that total bear of a Cochrane review. Splendid job. And I think you definitely hit the big points of it. And that being that the dark horse in this race was honey. I would love to somehow find a YouTube video of how they applied this and like how you keep it on. And again, I kind of was jokingly making a comment, but like, what if, like, how do you take it off? Do you like just lick it off your skin? Like, I don't know. So a lot of questions, but I think it's a fantastic resource that we have. I think honey is becoming a little more expensive these days, but who knows? And in a few moments after people get their thoughts out on their take on this, we'll kind of go over what Craig sent us in regards to what we have on formulary and the cost of certain antiseptics that we have here. So I'll open this up to anyone else who has comments to make. Please go ahead and say them.
Alec, was that Cochrane review fun to read?
No.
So the problem with the Cochrane reviews is that the readability is inversely proportional to the depth of knowledge you gain from it, right? And the user friendliness. So the preferred way of doing this sort of a wide breadth analysis would be to do this systematic review either through Cochrane or independently, however you want to do it, and then do a guideline based upon that systematic review. So then the guideline just breaks it down to the most important questions and the clinical take-home point with the confidence in that recommendation. The guideline would be a 10 to 15 page document versus this 200-page document, but the guideline would be based upon the 200-page document. Who in emergency medicine makes guidelines?
Chris Carpenter?
Nobody. There's not one agency in emergency medicine that makes guidelines. ACEP has clinical policies, and they've chosen years ago not to call them guidelines because they think that clinical policies are a little less onerous in court. The guideline makes it sound like every emergency department, every physician should be doing this. A clinical policy is more of a recommendation, but nobody in emergency medicine makes guidelines. What's this grade thing that they kept talking about?
The what thing?
The grade, the grade method they use to assess the quality of the evidence. What is that?
Are you referring how? Oh wait, I think I know what you're talking about. I did not know what they were talking about when they mentioned the grade.
Okay. Grade is developed by the guys who started evidence-based medicine at McMaster, and pretty much endorsed by most guideline forming agencies in the world now. There's 300 or 400 agencies that have endorsed grade. And what grade does is you first look at the strength of the evidence, and then you can upgrade the strength or downgrade the strength based on things like imprecision, like you talked about, and directness, like you talked about, the wide confidence intervals, or not lack of reproducibility. So a lot of those things that you presented, the low risk, or the low confidence, very low confidence, moderate confidence in the recommendation is based upon, they first looked at how strong the effect was, and they downgraded or upgraded based upon those factors that grade points you towards. And unfortunately, emergency medicine, our clinical policy committee does not use grade right now. They use a system that they devised in 1992. It's very difficult to reproduce or to understand. So just if you are reading guidelines, you'll want to understand the grade process.
Chris, did you also talk about with the grade process how they bring in clinical applicability, part of their strength of their recommendation?
Yep. And it does take some training. The grade is not something you could just walk in tomorrow and apply grade to a pile of evidence. There's courses that you take. Actually, the people who really do grade well take the course every year, because grade is constantly being updated. There are arguments against grade. The arguments against grade are there's no randomized control trial showing grade is better than, say, ACEP system. There's no evidence at all that grade is better. There's not even observational evidence that grade is better by any measure than any other system that's ever been used to grade the quality of the evidence or the strength of the recommendation. And there's some proprietary interest there, because the folks who teach the grade course and who sell the software is called GradePro, make money from that. And they use that money to bring guidelines to developing nations. That's what the money goes towards, but it is a money-making entity. And so there's folks who are uncomfortable using grade for all those conflicts of interests. I should also say that Cochrane, the reason they look at things like honey is because these guidelines aren't for the US or for North America. They're for the whole world. And in some places like sub-Saharan Africa are never going to have sulfur sulfadiazine to use on their patients, but they do have honey. So that's why they looked at those things.
All right. Well, I'm going to just read off Craig's email real fast. And thank you guys for chiming in on the grade stuff. That is kind of scary. It's just so vast with research these days. But I think that's amazing, and it helps to propel our field forward. So thank you for breaking that down a bit more for us. So Dr. Carpenter and I had reached out to Craig to see kind of what our options are. Again, as Dr. Carpenter had said in regards to the Cochrane Review, this isn't just what's based in America, but kind of globally. So here, Craig actually is showing a little bit of a sense of humor. He says in regards to the prompt that we had, just tell the girlfriend that silver is an element. How much more earthy natural can treatment with silver-based therapy get? Her big bottle of lavender essential oil that will be necessary to calm him or her after the ER bill hits the college rough housing near fire will be necessary to a small jar of generic Silvadene. If a 1 pound jar of Silvadene is necessary, then the cost may equate to crystal purchase and a trip to the Collinsville dispensary. So joking aside, so things on formulary that we have here. So silver sulfadiazine, a small jar costs less than $10. Good to know. Silver nitrate, this would be a compound topical liquid, cost between I'm so bad with this, methadone and Silvadene. Hard for me to obtain. Mefenamide, a small jar, is about $50 to $60. I'm sorry if I'm butchering this. So silver-based therapies, 3 are on formulary and would be ordered in Epic using generic name as above. honey not carried in a pharmacy, but maybe it's in our turkey sandwich drawer or something like that, or in our cafeteria. Not available under orders. So he writes, unsure how to obtain. Aloe vera, regular aloe vera gel, not available. Iodine-based, the solutions are available in our topical cabinets in the ED. Ointment can be ordered from the pharmacy in Epic. Chlorhexidine or polyhexanide, chlorhexidine prep and bath solutions are available, but he's not sure fully how to obtain. The 4% solution is available under bathe patients order in Epic. Sodium hypochlorites you can order by typing in DAKINS, and merbromin no longer available in the United States, removed due to mercury content. Good to know. The ethacrynide lactate, not available in the US. He says he did find a foreign-made product on Amazon, which could be delivered in 4 to 7 weeks. Kind of takes us back to that tox patient who ordered, I'm blinking on what it was. Was it arsenic online?
Arsenic. That was my girl.
We're going full circle here with you, Alec, aren't we? And then cerium nitrate, not available in the US, and Arnebia euchroma, not available in the US. So good to know that some things we just don't have here. And also, again, thinking about our patient population, the price, if we're going to say like, hey, I want you to apply this a couple times a day or a couple times during the week, what options they have. And you know what, maybe honey is the most cost effective antiseptic that we have. Any other thoughts? Feel free to go ahead and bring them up. If not, we'll kind of jump to the final word here.
Regarding the Cochrane reviews, I just wanted to walk people through the history of the emergency medicine Cochrane reviews a little bit, because this isn't an EM Cochrane review. This is a surgery Cochrane review. Emergency medicine 3 times in history has had a Cochrane EM section. Once was started in Australia about 20 years ago, folded after a couple of years. Another time, 10 years after that, it started in France and folded in a couple of years. And now, as of last year, we now have a Cochrane emergency medicine section, again, led by Mike Brown at Michigan State, who's actively looking for folks to review Cochrane reviews, prioritize EM-specific Cochrane reviews, and write Cochrane reviews if you want. And he's putting together some workshops for the U.S. to learn how to write Cochrane reviews if you're interested. The reason that that's important is because when there's not an EM Cochrane section, we have to go through the surgeons or the anesthesiologist or whoever the Cochrane group is that we're writing content for. And most of the time, they don't see the emergency medicine applicability for it. As an example, I tried to do a Cochrane review with the Canadians 3 years ago on PCA pumps from the emergency department. And there are, at that time, there were 3 randomized controlled trials based in the ED of PCA pumps for pain. Because we know that many of these patients are admitted to the hospital and wait for hours to days in the emergency department with prolonged waiting times, and PCA pumps could get started in the ED. The anesthesia group that was based in France felt that that was not an emergency medicine issue. Recall the emergency medicine in France is anesthesiologists in an ambulance, not emergency medicine physicians in an ED. So these are the folks who are making the decision about applicability to emergency medicine, and we didn't get to write the Cochrane review because they were the ones judging it. So just bear in mind, we now have an EM Cochrane section.
Of note, I forgot to mention that all the honey-based, or most of them were actually, they were using raw honey or unprocessed, undiluted, pure honey, which runs about $15 a bottle, looking on Amazon.
Oh. Thank you for the clarification. That's maybe that's another study that can be done, looking at our, Schnucks brand honey versus raw honey. So the future of research is bright and open to the taking.
In the ED and the Pyxis, we do have the Aquacel silver impregnated wound burn cover dressing. So
good to know. All right. Well, thank you everyone for joining. I'm going to kind of go over the final word. This is my take on it. And a big shout out to Dr. Cohen for still being here as he's rehabbing. Hope you're doing well. And to Dr. Chris Carpenter. You two have been great in helping me stumble through this process. I hope I will maybe be invited back someday to do this again. I wasn't too bad, but thank you guys so much for helping me with this. And thank you everyone for joining. So I'm going to go over my final word. Please feel free to chime in, Dr. Carpenter, or anyone else who wants to add to your take on this. So just kind of recapping everything. So there is a lot of literature out there regarding physiologic and biochemical components of burn blister fluid and what that means, but not a lot about what that means for us clinically in regards to how we can best help our patients and our patient-centered outcomes. So, for instance, some of the studies didn't really go over, pain for the patients, cost of interventions. Most of them did discuss healing and also kind of bacterial cultures and colonization, but not so much what infection was or morbidity, mortality. So unfortunately, these studies are not great, as I just kind of mentioned, but they are what we have now. And I'm going to kind of agree with the articles that were published in the Emergency Medicine Journal in 2006 by authors Shaw and Dibble. And they kind of looked at this EBM topic. And they concluded what I am going to agree with here, which is that leaving thermal blisters intact does show a trend for decreased infection rates and helps with pain, and that it should be an option for our patients, just leaving some of these blisters intact. But again, I think as Dr. Carpenter had mentioned, making this a patient-centered discussion is perhaps the best thing that we can do for our patients. So something to think about. As for the antiseptics, move over silver sulfadiazine. Honey is coming for you, okay? So maybe not quite the reigning champ that we think it is, but again, not something that we easily have at our disposal in the emergency department. And also silver alone, not so much used for killing werewolves anymore, but does help to promote healing and some antiseptic techniques. So, with that being said, those are my thoughts on this journal club. Thank you everyone for coming, and hopefully this has been beneficial. And I know for myself in the future, I feel like maybe I will not be so quick to say, no, I got to debride this or anything like that. But again, this is a great topic for future researchers to consider tackling. Any other thoughts are welcomed.
I just want to say one thing. Thank you, Nicole, and thank you, Chris, both of you guys for taking this on for me while I'm recuperating at home. I really appreciate it. This was a great journal club, and it's nice to see these things happen even when I'm not able to lead the way. So thank you.
Get better, Brian.
It's so good just to be able to see you, Brian.
Oh, thank you. I'm doing much better. I'm alive and well.
It's great to see you looking so good.
Thanks, Tiffany.
Great job, Nicole.
All right. Thank you, everybody.
Thank you. Have a good weekend.